Good afternoon, everybody. So now we move from surface to intraocular tumors, that's retinoblastoma. May I invite Dr. Usha ma'am and Dr. Anirban to please come forward.
Dr. Vikas, we can start.
Yeah,
All
please
right,
start.
yeah.
Please start.
Yes, so good afternoon, everyone, and thank you, Dr. Vikas, for having me here in this session on retinoblastoma. So I will be taking you through the very basic aspect of retinoblastoma, and especially, targeting the postgraduate students on update in the diagnosis and classification. I'm Dr. Fairuz, ocular oncologist and a retinoblastoma specialist. I'm grateful to my team of retinoblastoma, including the pediatric oncologist, radiation oncologist, everyone who has been working with us on retinoblastoma. So one important thing that I want to emphasize here today is retinoblastoma is a clinical diagnosis. And that is exactly why we need to know the classification, because depending upon the features, the clinical features, that is how we classify it into different groups, into the tumor, nodal, metastasis, etc., etc. There are a few things that we require for this, and in our clinical practice, it's just not a clinical evaluation, seeing the patient in the clinics. We do take these patients under general anesthesia and do a very detailed evaluation. And in fact, the documentation is so very important, because depending upon each and every minute feature of the tumor, that's how we classify these lesions. And why? Because depending upon the classification and the staging, that is how we actually decide our management protocol. All right. And well, there are investigative modalities, which is in fact additional. So again, retinoblastoma is a clinical diagnosis. So this is basically the clinical classification of retinoblastoma depending upon the features. So we have exophytic, very basic, I'm sure all of you know about it. Endophytic. Endophytic is where the tumor has grown into the vitreous, so it kind of spits out vitreous seeds. It could be focal, it could be diffuse, and this is how the endophytic tumor looks like. The mixed, it can have both exophytic and endophytic component, and a diffuse infiltrating, where the tumor is diffusely involving the retina. You actually see like a very very thin retinal thickening and discoloration of the retina, which is of course white in color with specks of calcification, as you can see here. Now this is quite a recent clinical classification of retinoblastoma, where this is a patient who did not have absolutely the retina up to the pars plana was absolutely normal. Retinoblastoma arises from the retina, but this was an anterior segment presentation of a retinoblastoma. In fact, initially the child presented with a uveitis picture, and gradually the child started growing this small lesion in the corner of the angle, did an FNAC, and it was confirmed to be a case of an diffuse anterior segment retinoblastoma. You should keep this in mind, especially in older children. They can present with this kind of a scenario. Now, we have been recently doing a lot of work on vitreous seeds in retinoblastoma, which is something has been very difficult to treat, and currently we have this intravitreal chemotherapy that we have been extensively using in controlling these vitreous seeds, and then subsequently we also started classifying the vitreous seeds in order to assess the outcome and prognosis of vitreous seeds. So this is how we basically classify into spherules, like as it clinically appears. It can have dusting, it can be like having a dusting in the vitreous, and also clouds. So this is the very basic classification of the vitreous stage. Now, grouping and staging in retinoblastoma. So grouping is basically for prognosis of vision and eye salvage, and staging is basically for prognosis for life. All right, so current classification system that we use is International Classification of Retinoblastoma. I'm sure all of you know about it, A to E. It's very easy, universally used, which was put forward in 2003, and the American Joint Commission of Cancer, AJCC TNMH classification, TNMH, mind it. So retinoblastoma is the only malignancy in the body which has given an H to the TNM. Usually we have heard about TNM, but retinoblastoma being a genetic disorder, it also has an H. So students, remember, whenever you talk to your examiner, when they talk about TNM classification, add an H. in retinoblastoma. All right, yeah. So I'm just going to make it slightly easier for you, kind of taking you through the grouping and the TNM together so that it's easy to remember, although you'll have to go and revise it again. So we have group A, which is like small, A for small, less than 3 millimeters in basal dimensions and away from the fovea and the optic nerve. That is group A. Group B stands for big and B also stands for bubble. So it will be more than 3 millimeters in size and it will have bubble in the sense it will start having exudative retinal detachment around. Okay, so there will be subretinal fluid around the tumor. So that stands for B. Now correlating this to the clinical TNMH classification. So we have in TNM T1 where we have tumor less than 3 millimeters in size and 1B which is more than 3 millimeters in size. So T1 there is one component which is taken care of, that is size, and this correlates to group A and group B. Okay, T1 which is actually group A and group B, kind of correlating to it. Now C and D is a stage where we start having seeds. It could be subretinal seeds, it could be vitreous seeds. Now C stands for confined, where there is a focal seed. D stands for diffuse, where there is diffuse seeds. Okay, so this is C, group C with confined seeds and group D with diffuse seeds. All right, now let me switch over to the CTNM again. So in CT2, they have fluid and seeds. All right. A is with subretinal fluid, B is with vitreous and subretinal seeding. So in T2, there are two components which is being taken care, fluid and seeds, which is again correlating to C and D. Okay, done? Perfect. Don't forget it. All right. Yeah. Now we have group E. E is an advanced intraocular retinoblastoma where we have all the clinical risk factors which can have a possibility of a systemic micrometastasis, including neovascular glaucoma, massive intraocular hemorrhage, aseptic orbital cellulitis, and that is due to necrosis of a large tumor which actually presents like an inflammation. And after a very bad inflammation, in fact, these eyes can go for phthisis also. You know, the entire structure is altered, and then you can even have a phthisis bulbi in retinoblastoma, and that is group E. All right, yeah. Now, group E is very extensive, and that correlates to T3. Okay, T3 is advanced intraocular tumor, and depending upon the severity, phthisis, pre-phthisis, tumor invasion of the anterior segment, raised IOP with ophthalmos and neovascularization, high FEMA, massive vitreous hemorrhage, aseptic orbital cellulitis. In T3, there is A, B, C, D, E. All right, easy to remember. Perfect. All right. So that is how group E correlates to. Now T4 is something where it has gone outside the intraocular confines. It has gone out of the eyeball. That is T4. Now depending upon the involvement and the extent, again there is T4A and T4B. When newer classifications comes into work, we always dissect it as clinical practitioners. So there is a little bit of issue with this classification over here. Okay. Now I'm going to tell you that. So there is a radiological evidence of retrobulbar optic nerve involvement or thickening of the optic nerve involvement or the orbital tissue. Optic nerve involvement in retinoblastoma is the most dangerous. You know that. Optic nerve is connected to optic chiasm, brain, and there is a high risk of central nervous system involvement if the optic nerve is involved. But if it is only related to the orbit, it's an extraocular extension but not involving the optic nerve, no CSF being involved, it actually has a slightly better prognosis than an optic nerve involvement. So some of us believe that T4B should be actually slightly better than the T4A, right? Yeah. So, well, we have mentioned this to the organization who have come across with AJCC. Obviously, every classification, every system, there is an evolution and change. So, probably this comes out in the next edition. Yeah. So, this is something like very glaringly not acceptable, all right? But this is how it is at this point of time. So yes, R is for regional lymph nodes, metastasis. Now metastasis, again, we have M1 and M1A and M1B, tumor involving distant sites like bone marrow, is slightly better prognosis than that with the CNS involvement, as I told you. All right, yeah. Now, hereditary, I already told you. TNMH classification, even there is a pathological TNM classification in retinoblastoma. When you take out an eyeball, enucleation is not an end of a retinoblastoma treatment. It goes to the pathologist, all the high-risk features are looked into, and even they have a TNM classification, that is pathological TNM classification. As a treating specialist, what I need to know is whether there is a high-risk feature or not. All right, yeah. So in T1A, it's without any local invasion. In fact, there is no local invasion, so the possibility of high-risk features is very, very less in PT1, whereas in PT2, there is focal choroidal invasion and prelaminar or intralaminar involvement. That is high-risk feature. So T1, no high-risk feature. PT2, yes, high-risk feature. PT3, lots of high-risk features, massive choroidal invasion, retrolaminar invasion of the optic nerve, scleral involvement, full thickness involvement of the sclera, and these are dot on high-risk features pathologically for retinoblastoma. And well, PT4, as clinically you know, pathologically also, if there is evidence of extraocular extension, it is PT4. Now, orbital retinoblastoma, in our part of the world, we see this extraocular extension. So this is actually put forward by Dr. Santosh Honavar, and we do practice this in our clinical evaluation of orbital retinoblastoma as primary, where they initially present with extraocular extension, secondary, where they have undergone enucleation, but then there is an orbital recurrence of the tumor, accidental, where, you know, some surgery like, retinal detachment surgery, vitrectomy has been done in these cases, and there is an extraocular extension, overt, where radiologically you have missed it, but there is a surprise on table when you do an enucleation, there is a slight extraocular extension, and microscopic. Now, international staging system, as I told you, for life salvage, stage 1, where it's entirely removed, stage 2 with microscopic residual, 3 with orbit extension, and 4 is metastatic disease. So applying staging and grouping in retinoblastoma is very, 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 very important, not only for documentation and also for taking decision for management in retinoblastoma. I say appropriate decision. All right. So this is exactly how we do it. We identify the disease, laterality we identify, we apply the group, we apply the stage, and then the treatment status in all these patients. So well, a thorough detailed history is so important, clinical examination is so important, and definitely classification and staging in retinoblastoma is very, very important. Thank you so much.
Thank you, Dr. Fairuz. That was excellent, especially putting the TNM staging and the ICRB grouping together into proper perspective. So next we have Dr. Usha Kim, who is head of Arvind Eye Hospital, Madurai, and has developed one of the probably biggest genetics labs in this part of the world, which is working a lot on the subject of retinoblastoma. Madam, over to you for genetics.
Thanks,
That's the
Dr.
hope for the
Vikas.
future in retinoblastoma.
I've loaded it already. The preview room. Yeah, it's already done. No, it is loaded in the preview room. Genetics and retinoblastoma. I know after a good meal, genetics is not a very palatable topic, but I'll try to make it interesting with few of the case scenarios so that you understand the relevance of the genetics. Yeah. So, first, for all of us to understand, we need to understand that the 4 bases that are very important. That is the adenine, thymine, the cytosine, and the guanine. So these are the 4 important bases, and any skewing in this is what results in the formation of a retinoblastoma or a tumor. So I don't know, just to keep your interest high, any guesses on how many bases are there in the human body? The human genome has about 3 million base pairs. 3 million base pairs. And any skewing in any of these will result in a problem. So we have to remember a few terminologies, and I'll explain what the few terminologies are. So you must understand these letters should not be mismatched. So A pairs with T, C pairs with G. So this is very, very important. Now, in nonsense mutations, the nonsense mutations is one of the important ones we'll be seeing in during the course of my presentation. They are caused by a single base change. A single base change creating a stop or truncating. Anything that stopped or truncates the entire protein. So you must remember that about 30% of the retinoblastoma mutations are nonsense. They can be the definite cause for the disease. So just one single change can result in stopping or truncating a protein, which could result in 30% of the retinoblastoma hereditary cases. Now this missense mutations causes change of an amino acid that can alter the protein sequence, and it's more or less relative to the when you compare it with the nonsense, the missense is slightly less penetrant. So there is a role for penetrance. The nonsense has a higher penetrance, whereas the missense has a lower penetrance. These are also important for us to understand the genetic inheritance pattern. The silent mutations do not cause any problem. So that's why when you screen the gene, you'll have a lot of mutations, but all of them are not very relevant. Now, why are we talking so much about this RB gene? That's the gatekeeper. When something goes wrong with it, ends up in proliferation of cells, resulting in the tumor formation. That's all you need to remember. Now, in retinoblastoma, you know the non-heritable adds up to about 60%, while the heritable adds up to a 40%. And it's very, though the ratio is a little lesser, it's important for us to look at the heritable entity, because this 40% is going to cause a problem in the offsprings, and there's going to be a whole community of patients with retinoblastoma. So that's very, very important for us to concentrate on the heritable one, and hence the heredity aspect is added to the classification. So you all as students should remember that one allele in the RB1, as far as the inherited retinoblastoma is concerned, one allele is already inherited. That is, every cell in the body will have that mutation, and the second mutation happens in the retina. So this is important for us to understand. So that becomes the inherited entity. Whereas in the sporadic entity, which is non-inherited, you will have both the mutations occurring in the retina, which means the rest of the cells are devoid of the mutation. So what we did initially to start with was we revisited the nonsense hypothesis. I think somebody didn't like the nonsense hypothesis being revisited.
Lots of technical issues in this hall actually.
This is a jinxed hall.
All right.
We need someone who is like.
I thought only the ophthalmic arena didn't like us. Even the audiovisual don't like the oculoplasty. So as I'm waiting, I'll just continue talking about we used to have patients, either of the parent would come and give us a very vague history of having lost an eye, and it was very difficult for us in those days. Not that we're all antique, but at least 20-30 years ago, not much of importance was given to a socket which did not have even an artificial eye. I think probably about 20 to 25 years ago, it was not uncommon for us to see empty sockets, and we had no history from the patient telling us what exactly went wrong. So on looking at it very carefully, if you look at the Knudsen's hypothesis, which clearly gives you the two-hit theory very well, explains it very well. The one thing that was very glaring was we used to have bilateral cases presenting to us very early and unilateral cases presenting to us later, and which corresponded to the two-hit hypothesis as well. That was the first thing we did. Then we strategized and we started doing an analysis where we established a stepwise methodology for analysis. First, we did the Sanger sequencing. All of these are terms you might have to remember for your examination purposes, and those interested in research have to read a little more about this. So the basis is what I explained. It is all to do with those pairs, and if those pairs are skewed, you will end up with having a nonsense or a missense mutation. A nonsense mutation has got a high level of penetrance, and nonsense mutations are predominant in our population. So here we looked at the point mutations as well, and then I'll talk about this MLPA a little later, where you'll have deletions and duplications. Now this facility is what helped us to run our testing very fast. The next generation sequencing facility helped us to find out the variants in the RB1 which could not be identified with our conventional methods. So this was important for us. And the other important aspect is it's faster and gives you in one go you can put about 100 samples altogether can be screened. So the next entity is the promoter methylation analysis, which was found out in about 4 of our patients out of the 500 and odd specimens that we handle, the patients that we handle. But these were not found in the blood. So it is important to note that this promoter methylation actually was found in the tumor and not in the blood. So this is an epigenetic change that has occurred and is somatic and cannot be inherited by the next generation. It's very important for us to understand this. So when something is not found in the blood, it will not be inherited by the offspring. The next one is the Mikan amplification. This is a proto-oncogene and its amplification is independent of the RB1 inactivation. This can cause RB. This per se can cause RB. So the Mikan amplification per se without any mutation can cause RB. So high Mikan copy numbers was seen in about 5 of our tumors of unilateral patients. Please remember, these are unilateral patients. Often we are told that unilateral patients do not pass on the tumor to the offspring, or it need not be inherited. It's not true. I'll show you examples. Mikan has another aspect to it. It's an aggressive tumor with a very poor prognosis. Again, all of these will have relevance in terms of management, and all of these will help us to prognosticate and tell the patient well ahead whether this is going to be chemo-resistant or chemo-sensitive tumor. So in our map, we had about 140 mutations which were noticed, of which 20 to 24 of them were very unique to our particular population. That is the 500 and odd cases that we screened, and of which nonsense predominated, followed by missense. And I told you earlier, nonsense has a high penetrance. Now, so we established the genetic testing center, and we have a sensitivity about 95% for somatic mutations and 85% for germline mutations. And this is actually, I would say, we are not very behind the other established centers in the world. And what's more important and relevant to us is the cost has been brought down significantly from $1,800 to about $150 to $200. And the time taken for the entire testing to be completed is about a month, which means the patient comes first a month and gets the examination done. In some cases, enucleation can also be done sometimes we start off with chemotherapy. So when we start the first cycle of chemotherapy, before we start, we draw the blood and do all the workup. And then once the patient comes back for the next chemotherapy, we're able to provide with the results. So what do we do actually in terms of the testing, and what is the relevance for a patient? You are able to prognosticate one, but more importantly, you're able to predict for the offspring, for the sibling, and also you can preempt whether this patient is going to be a bilateral case in cases of unilateral cases, and I'll show you some of the examples. Now, this was a child who was brought with a bilateral retinoblastoma. Unfortunately, we had to enucleate one eye. But on history, we found out that the mother had a empty socket. If you notice, the right eye is an empty socket, and she has had an enucleation, but she did not give us any history as to what had happened and why the enucleation was performed in this patient. And eventually, we drew the blood for both the patient and the first child, and found out that both the mother and the child had a similar mutation. The pattern was very similar, and as we were doing it, the next child was ready to be born, and we predicted that the next child is going to have a tumor, and the child did have a tumor, both eyes. And since the child was brought in as early as 12 days, we were able to treat both the eyes and not only salvage the globe but also the vision. So that is one way of predicting the occurrence of retinoblastoma. Now here is another classic example where a twin was brought to us. One twin had an obvious retinoblastoma while the other had a suspicious lesion. So in order to find out whether the other twin is also having a retinoblastoma, we had to do an analysis, genetic analysis, and we found out that the other sibling did not have any risk of retinoblastoma. So we need not unnecessarily keep giving anesthesia for the patient and examining the other twin which had a suspicious lesion. Another example here is, this was a unilateral retinoblastoma group E with no family history, and a germline mutation was identified in the blood. So now I would emphasize that it is very important for us to do genetic analysis even in unilateral patients. Now this is another example where the father was an unaffected carrier. There was a germline mutation identified and the patient was closely monitored. So the right eye had group E retinoblastoma, and as the patient was getting treated, the risk was predicted that the next sibling would have a chance of retinoblastoma, and the sibling screening was done, and the familial germline mutation was found. A high risk of developing RB in the sibling was predicted. Father's eye was normal. So please remember, father is an unaffected carrier. The father's eye was normal, and the first child had a similar mutation like the father. Father unaffected, child affected. Sibling had a high risk of, the next sibling had a high risk of retinoblastoma. So the next sibling was brought in very early and found out that both the father, the children carried the same mutation. So why am I stressing on early arrival is, when the child is brought in early, the treatment is easy and you can salvage not only the globe but also the vision. Now there is another aspect to it. Now with all this happening, people have started coming forward. The old cases of retinoblastoma now are coming to us asking for a genetic analysis. One such patient had turned up and said, I would like to get screened to know whether when I get married, would my offspring be affected? And genetic screening was done, and fortunately the blood showed a negative for mutations, and then she also has given birth to 2 children, both of whom have been screened, and they've been found to be negative. Now, secondary cancers is another aspect. Again, now again children are coming forward and asking for any possibility of secondary cancers, And with the genetic screening done in the blood, it has been proven that some of the children are negative for mutations, and hence there's no risk for secondary cancers. Now, this patient, the grandfather had a brain cancer. There was a history of some cancer in the family, and there were generations which are affected. So here the history goes such. The proband had a bilateral RB, and this particular deletion, you don't have to go into that aspect. This particular deletion was inherited from his father, who again is an unaffected carrier. Now, we explain the risk of RB in the next sibling. Immediately after the birth, the child was brought in, and fortunately in this case, the next sibling was found to be normal. So, there are very good aspects to it. One, you can give a negative result, which is very good for the patient. You can give a positive result, which again is good for the patient because they are brought in early and treated, and the vision and life is salvaged for such patients. And of course, we had one unfortunate incidence where the proband had inherited the retinoblastoma. The proband's wife was pregnant, and we had to do an amniocentesis, and we found out that the fetus also had positivity. Unfortunately, the twins, they had to terminate the pregnancy. But we have to be very, very careful in terms of counseling these patients. The onus is on the patient to determine how to go about. So here, it's only the results we have to provide for the patient. So in summary, tumors are caused by genetic aberrations. It does not mean that all patients will inherit the disease, and it does not mean that tumor in all cases are heritable by the next generation. So we'll have to understand this very clearly. So in terms of heritable disease, there is high risk of other cancers, increased risk of RB in siblings and offsprings, and usually the alterations are found in the blood. Whereas in non-heritable, there is no risk of other cancers. There is reduced risk of RB in siblings and offsprings, and usually the alterations are identified only in the tumor. Thank you very much.
Thank you, ma'am. That was very useful. For all of us who are seeing retinoblastoma patients, the one question that we are frequently getting is that, what will happen to the subsequent children, and what will happen to the siblings of this particular child. And there's no precise way to predict that, and unless you do that genetic analysis, which is very important nowadays, and with the facility being available at such low costs that you have mentioned, that really becomes very, I would say, feasible for anybody who's interested in knowing the exact prognosis and the familial the implications of having a retinoblastoma gene in the family. So thank you very much, ma'am. And also, if these patients are brought in early, when you can really pick up the gene in the family, that can really save their vision, not just the eye. So that's the importance of this subject. It may be a little tough to understand, but it's really clinically very relevant, and more clinicians and geneticists are working together everywhere else in the world, and I think that's something which will happen in future in India also. So that's where probably we are headed. Thank you, ma'am. Next, I would like to invite Dr. Anirban Bhadri for presenting on various clinical manifestations of retinoblastoma. Dr. Anirban Bhadri is a very senior ocular oncologist in Calcutta and has decades of experience in managing retinoblastoma in that side of the country.
I'm not as decades old as Vikas describes me. Thank you, Vikas, for having me on your program. We all learned our retinoblastoma from Dr. Santosh Honavar. Yes, it was a few decades ago. So what I'll be doing is talking about this aspect of retinoblastoma. Ferus has actually shown you some examples of other presentations of retinoblastoma. So first thing is, what is a masquerade? A masquerade is actually a party. It's a dance party, a ball where people wear masks so that others don't recognize them. And retinoblastoma is actually one such disease. So why this topic is being discussed is because this one particular child whose story hurt me more than anything else. So this was a child who was 4 years old. He was diagnosed with endophthalmitis in an institution where he underwent a vitrectomy and intravitreal antibiotics were given. And this child did not get better. He was actually taken to another institution where he was eviscerated. And a month later, this is how he turned up. Okay, so now you have a frank orbital retinoblastoma thanks to intervention by our colleagues. And this is exactly the problem that we want to discuss so that such incidents don't happen. It's very heartwarming to see so many people in this hall. Earlier we would have 3, 4, 5 attendees to an oncology session. Things are getting better. So this is what we usually see as retinoblastoma, right? Leukocoria. Of course, the leukocoria could have other causes as well, but this is one presentation which most ophthalmologists recognize. The other is, of course, a fungating mass. Now, this again is something which is very obvious. Now, between these two spectra actually lies several other presentations which are not so easy to diagnose, and the entire purpose of this would be to create awareness so that we look out for retinoblastoma. So, these are some of the other presentations, and the LV Prasad group, they had published a very large database. And if you notice that the first two presentations, that is leukocoria and proptosis, that takes care of about 81%. So about 1 in 5 retinoblastoma patients actually present with something else. So let's go over each of them one by one. This is a child with a early esotropia, right? But if you look very carefully, there is a, okay. So you see this little white glow here. Now, what was the first presentation of the child was the squint itself. Now, just a simple dilated examination revealed that there was a tumor in the macula. Now, if all our colleagues examined every child presenting with a squint on the first instance, by a dilated fundus examination, you could pick up retinoblastoma in these children earlier, instead of letting it go. Koi baat nahi, there is a squint, let the child get older and then we'll take care of it. So that is a common response, but that shouldn't be the way we should be dealing with these patients. The next is ophthalmos or pediatric glaucoma. Now, many of these children, when they develop neovascularization of the iris, they go on to develop glaucoma. They present typically with ophthalmos. There is a hazy cornea. You cannot see the fundus. And there have been instances when these children have undergone trabeculectomy with trabeculoplasty, ending up with a metastasis. Dr. Honavar used to show us one particular slide with a child presenting with a huge lymph node. All that you need to do in such patients is, before you go and start glaucoma therapies, just do an ultrasound. Okay, a white eye with a hypopyon. Now there is also, you can see the shifting fluid here, and if you look very carefully, there are tiny iris nodules as well. So should we first think of JRA in these patients? Again, do a good examination, EUA, ultrasound examination, and you would find the cause. I'll show you one particular case which was gifted to me by one of our colleagues, Dr. Seema Das from Delhi. And this is a child who again has iris nodules. There is a thick white hypopyon, white eye. But as Feru showed in one of our cases, look at the fundus. On a cursory fundus examination, the fundus looks normal. And this is a CT scan of this patient. We'll come back to this once more. This is what was seen on EUA. So you had 2 small tumors in the periphery seen under anesthesia, and they were seeding in the pars plana as well. And this is the only evidence that we have of the tumor in this patient. So this is an anterior form of retinoblastoma. Okay, hyphema. This is a child who's undergone a hyphema drainage. There is a small suture here. This eye is slightly smaller than the other eye. And this is an ultrasound of that patient subsequently, which shows that there is a mass with intralesional calcification. What was tragic is that the other eye had not been examined, and this child had multiple tumors in the other eye as well. And this is an MRI of the child, which shows a very well seen tumor in the better eye. So, simple thing, ultrasound for every patient that you see, where you want to go and do some intraocular intervention, and please do a dilated bilateral examination every time a child is taken up for an examination under anesthesia. Vitreous hemorrhage, this is a very obvious case because you can see the tumor in this portion, but sometimes the vitreous hemorrhage can completely obscure the fundus. This child has other features of neovascular glaucoma like this ectropion uvea that you see here. But again, if you have vitreous hemorrhage and you want to intervene as a VR surgeon, please first go ahead and do an ultrasound. Simple, cost-effective. Child with cataract, but you can see these iris nodules. This is a child with retinoblastoma. This is a child who has been operated for a cataract in childhood, and it's only after that that the retinoblastoma was revealed. So these are tragic incidents that should not happen if we are aware that retinoblastoma can have other presentations as well. Endophthalmitis, the first child that we showed you who ended up with orbital retinoblastoma, is a common misdiagnosis because when retinoblastoma undergoes necrosis, there is intraocular inflammation which can later on spill over to the orbit as well. So this is one of the presentations. So what are we actually looking for when you're doing an ultrasound in a child with retinoblastoma? The first thing is preferably do it yourself. Ultrasound is easily available in most eye institutions. If you do it yourself, you will not miss certain features. So what are we looking for? We are looking for a mass lesion. You will not have after movements in a tumor. You can have after movements in the vitreous seeds within the vitreous cavity, but not in the tumor itself. And you're looking for these bright spots, which are the signs of calcification. So if you run the vector through one of those bright spots, only then will you get these high spikes. And this is what we need to look out for. This is another child. So as Feroz said, that retinoblastoma, the clinical exam is a clinical diagnosis. So we wanted chemotherapy for this child, but at that point in time, this is a decade and a half ago, when the oncologist said, no, unless you give me a histological diagnosis, we are not going to give chemotherapy. Okay, another presentation. As we were saying that the inflammation can spill over to the orbit. This is sterile inflammation. Okay, you do an ultrasound and you'll find there's actually retinoblastoma lurking inside the eye. And it's not a classic infective orbital cellulitis. So just to summarize, retinoblastoma is a great mimic, and it's extremely important that we need to be aware of these difficult or these atypical presentations of retinoblastoma. So a child presenting with squint, glaucoma, a red eye, proptosis, orbital cellulitis, thysical eye, please rule out retinoblastoma before you go ahead with any other kind of intervention. And if you have proper evolution and imaging, as I was saying, we have very easy access to ultrasound B scan now. You would be able to pick up these cases and prevent a disaster. So please do not proceed with any intraocular surgery without ruling out retinoblastoma in these indications that we were talking about. Basically, timely diagnosis, referral and early treatment ultimately holds the key to survival. That is all I have for you. Thank you.
Thank you, Dr. Anirban. That was a really extensive variety of cases that you showed. So now that we have seen the classification of retinoblastoma, we've seen the varied ways in which it can present. So my task here is made simple by Dr. Anirban and Dr. Feroz. I will just try to simplify as much as possible the treatment approach that we take when we diagnose a patient of retinoblastoma. First thing to note is that when we read literature coming from the Western countries, we find that they report a cure rate of almost 100% for these cases. But when we compile the global data, as has been published, the cure rate comes down to about 30%. So that is really dismal. And what happens is that most of the developing countries, in which India is also part of that spectrum, so the results are not as good as what we see coming from the Western countries. That's primarily because of late detection and so many other socio-economic factors that we see in countries like India and other neighboring countries. So when we're talking about any kind of treatment, any kind of cancer, mainly there are three goals. That's the first goal is to save the life of the patient, the second is to save the eye, and the third is to save the vision or the sight of the patient. And then we have to, when the patient comes in, there are a lot of factors which we need to take into consideration, which will influence our treatment. Most important are staging, proper staging and grouping. Number two is the germline mutation, if the patient has a hereditary tendency or not. And then the socio-economic factors as the background from where the patient is coming from. And then whatever best resources we have are at our hand to treat. So all these factors we need to keep in our mind when we are deciding about treatment for any particular patient of retinoblastoma. And the text that we read or the books that we read or when we listen to the speakers from abroad, the way they are treating their patients is so very different from what we can achieve in our country because of various limitations, socioeconomic limitations, the patients from where they come from, their economic profile and all those things. Our factors are really different. So what I am presenting here is the treatment in the practical sense that we are able to follow in India, that we are able to manage in our setting, and not some ideal thing that we see in the publications or the textbooks. So some common pre-treatment factors that we need to take into account, as some of them Dr. Anirban also mentioned and Dr. Usha also stressed upon. First thing is family history, something which one can easily take in the OPD. Whenever a patient of retinoblastoma is there, sometimes we just jump onto the IUAO, do this, do that, but we forget about very important aspect, the family history. Does the child have a sibling? Does the child have a parent who was affected? If there is a sibling, how old is the sibling's age? And so you need to take all those considerations into mind and then plan your treatment. And then you do a detailed evaluation under anesthesia, where you do a detailed indirect ophthalmoscopy with depression, and you group the tumors as Dr. Fairuz showed according to ICRB staging and grouping. B-scan is easily available and already stressed upon what you need to look for. Need to look for calcification, and an MRI is essential to rule out an optic nerve invasion, an extraocular extension, or a pinealoblastoma in bilateral cases to plan proper treatment for these cases. Now, when you see a very small tumor, so very small tumor, that's like group A. So we have two very good modalities to treat these tumors, very small ones, peripheral tumors, 1 to 3 millimeter in size. So you can do cryotherapy, triple freeze-thaw cycles are given, and the only disadvantage is that with cryo, the scar produced is fairly large. So we have the other option, that's the laser transpupillary thermotherapy, that's the TTT, where we use a 810 nanometer diode laser, and the spot is delivered through a large spot indirect ophthalmoscope delivery system, which raises the tumor temperature to about 45 to 60 degrees, and that produces a subtle graying of the tumor. That's your end point. And for small peripheral tumors, simple TTT can be enough. For group A tumors, TTT also has a significant role as a focal consolidation measure along with systemic chemotherapy. Now, from group A, when we move on to the group B or further advanced tumors, that's a little larger tumors, we must know about the systemic chemotherapy that is available for these tumors. So systemic chemotherapy in a country like India is the mainstay of treatment. Still, we use 3 drugs conventionally, vincristine, etoposide and carboplatin, which are given under supervision of a pediatric oncologist. And then there is something called as chemocryotherapy. So when you are sending the patient for chemotherapy, if near the aura you put 2 spots of cryotherapy, that is supposed to increase the concentration of chemotherapy and the availability of the drug into the vitreous and to the tumor. So it's advisable to do that. Now, indications of systemic intravenous chemotherapy are if the patient has bilateral disease, if there is a confirmed germline mutation, even if it's a unilateral condition, if there is a family history of retinoblastoma, which again points towards a germline mutation, and if there is a suspected optic nerve, choroidal invasion, orbital invasion, or it's an advanced tumor, there again you require systemic intravenous chemotherapy. And there has been some talk about some protective role of in the prevention of long-term second cancers, though that is a little debatable. As we can see in this chart, the results with intravenous chemotherapy have been fantastic, with smaller tumors responding much better, and even in group E eyes also, there was almost 1/3 of those cases could have lasting tumor control where enucleation could be avoided. But then again, the management has to be tapered, so it's not just about chemotherapy. A newer thing that we have is intra-arterial chemotherapy, where you go directly into the ophthalmic artery and directly inject a drug which delivers almost 10 times the concentration of dose into the eye as compared to the systemic chemotherapy. 1 or 3 drugs are given. Dr. Fairuz would be talking about the details of intra-arterial chemotherapy. I will not go into much details of that, but it's mainly indicated for non-germline, unilateral, group B, C or D tumors. And there are reports coming in of it being tried in some group E tumors, but as of now, the general indications are for group B, C or D unilateral tumors. Now, when we have a patient who's come to us with a slightly larger tumor, so what do we do? So it's a group B tumor, which is a little larger than the group A tumors, that's less than 3 millimeters, as Fairuz mentioned in the classification, if you recall. So this patient presented with a group B tumor. So the option that we have is intravenous chemotherapy. Along with, after 2 or 3 cycles of chemotherapy, you start the focal treatment as well, which is in the form of TTT laser. And this is how the tumor regressed. So what happens is that with chemotherapy, the tumor starts shrinking, and once it's shrunken to a sufficient extent after 2 or 3 cycles, then we start adding laser therapy also on the surface, and usually these tumors respond well. Another interesting option is the IAC. Dr. Fairuz will talk about it. IAC has fantastic results, but there are cost implications and logistical implications in a country like ours. The technical know-how is not available everywhere. Cost becomes a barrier. So still we are relying more on intravenous chemotherapy compared to intra-arterial chemotherapy. Group C are cases which have got some sort of seeds. C is confined seeds. So basically these are confined seeds, means the seeds are close enough, less than 3 millimeters away from the tumor. And for such tumors also, we have option of intravenous chemotherapy to control the main mass. And also, if the seeds are not responding just to conventional treatment with intravenous chemotherapy, we have 2 other things, that is the periocular chemotherapy or intravitreal chemotherapy. Also, if it's a small peripheral tumor with a small set of seeds just adjacent to the tumor, then you can actually cryo the tumor as well as let the ice ball grow into the vitreous and freeze the seeds also along with it. And again, IAC is a very good option but expensive one. Group D tumors are those where the seeds are more diffuse, and again there are options like you control the main tumor first with intravenous chemotherapy and consolidation with laser. And for the seeds, if they are not responding to the main treatment for the main mass, then you have to go for periocular chemo or intravitreal chemo, or IAC if it's available and the patient can afford, very well. Or if the tumor is still very resistant, or the patient is somebody who's not able to come for follow-up, if it's a unilateral disease, enucleation is still a viable option in cases which are really bad, not responding to treatment, patient not able to come for follow-ups. All those factors you need to keep in mind. Intravitreal chemotherapy is something which recently has come into vogue, and was first introduced in 2003 by Kaniko. And so you have these vitreous seeds which are very resistant to to treatment at times, and you give intravenous chemotherapy, sometimes even after intra-arterial also you may have some residual vitreous seeds which are not responding because probably the drug concentration is not reaching those seeds enough, or they have some other form of resistance to chemo. So there intravitreal chemotherapy does help. So one is intravitreal chemo. You can give either melphalan or topotecan. 25 to 30 micrograms of melphalan is what is given, and 20 to 30 micrograms of topotecan. Sometimes you can give both the drugs together, and sometimes triple drug, which also adds carboplatin. The problem with melphalan is that it induces a lot of pigmentation on the retina, and after giving melphalan intravitreally, sometimes you see patients, especially in pigmented populations. So you see that the retina develops a lot of RPE changes, like similar to retinitis pigmentosa, and there are some changes on ERG also which have been noted. Other option is subtenon's injection of carboplatin 15 mg, which is given almost once in every 3 weeks. So these are the 2 modalities which we can try, either intravitreal or subtenon's or periocular chemotherapy for these vitreous seeds. The precaution that has to be taken is that when you inject the intravitreal chemotherapy for these retinoblastomas, your needle has to come out through the cryoprobe, through the cryo ice ball, and not just like that. And also there is a specific technique to give this injection. which is already detailed in literature. Group E tumors, the options are intravenous chemotherapy, especially if bilateral. However, if it's unilateral, then you can try either chemotherapy or enucleation. I would say if it's a very advanced disease, that's a better option rather than subjecting the patient to prolonged periods of chemo, when especially there is visual prognosis is not there, and unnecessarily prolonging the treatment. AC seeds, that's the anterior chamber seeds. Dr. Anirban showed a few cases of that. So these cases are till now into group E, and the standard treatment protocol was, and still is, I would say, enucleation. But few reports have come in, and which gives us some hope for the future from Munier et al. And they've introduced intracameral chemo. There's a specific technique to give an intracameral chemo. They go from clear cornea into the iris and then inject the drug near the zonules without touching the lens. So there is some hope in that on that front, where we are still enucleating most of these eyes. So maybe in future we'll have a better management for anterior chamber seeds as well. Radiotherapy, external beam is very rarely used nowadays unless it's an orbital tumor, as it was used to be a mainstay of treatment in earlier days, but now only it's reserved for orbital tumors, mainly because of the risk of second cancers following radiation in such young children. What we usually prefer is plaque brachytherapy instead. That's the focal or localized form of radiotherapy, which does not have so many side effects as the external beam full orbital radiation. So, but it's basically used for tumors which are resistant to the conventional form of treatment, where you give intravenous chemotherapy. You have tried intravitreal chemotherapy. You've tried whatever best measures you have. You've tried laser and everything, but the tumor still keeps coming back. It's not responding. So then in those cases, plaque brachytherapy is a very viable option with a very good success rate. And enucleation, as I mentioned, for massive group E tumors or bad group D tumors, where actually visual prognosis is not there and the tumor is not responding to conventional treatment or chemotherapy, or there is poor tumor visualization, which is making it difficult to assess every time. So in patients of extraocular extension as a part of multimodal treatment, not just if it's an orbital tumor, you don't straight away jump in for enucleation, but first you give chemotherapy. Dr. Honavar will talk about those cases, and it's part of that protocol. And if nothing else is working, it's an extensive tumor, you see that visual prognosis is not there. Instead of subjecting the patient to repeated cycles of intravenous chemotherapy, where the patient is coming every month, going back, and undergoing a lot of expenses as well as anxiety, it's better to just enucleate those eyes, especially if it's a unilateral condition. In bilateral, of course, you have to give it a try with chemo. The key thing here is that when you enucleate, you need to have a long optic nerve stump, more than 15 millimeters, what is recommended, and we normally put a primary orbital implant at the time of enucleation. And always subject the enucleated eyeball to a good pathologist who's experienced in seeing eyes with retinoblastoma. So what they will tell you is about confirmation of the diagnosis, that's first. Second, what's the differentiation of the tumor? Then what's the extent of disease, and if the patient has histopathological high risk factors. These are some of the factors which you see on pathology, which can predict, that which patient is likely to have micrometastasis. So if any of these risk factors present, that's optic nerve post-laminar involvement, anterior chamber seeding, ciliary body involvement, massive choroidal invasion, scleral invasion, or if there's an extensive tumor necrosis. All these patients, if they have this on histopathology of the enucleated eyeball, they are more likely to have systemic metastasis. So what happens if they have these, then you go in for bone marrow and CSF analysis and a systemic evaluation, and you have to give these patients adjuvant chemotherapy, which significantly reduces the risk of metastasis from an untreated patient to 24% to about 6% if you give adjuvant chemotherapy in these cases. So this is basically just a table summarizing what I have just spoken. In addition to this IAC, what is more important for us here is intravenous chemotherapy. So to conclude, we have a wide variety of options, and we need to individualize the treatment plan based on so many factors which probably are unique to our setting. And so early detection is good, and response is usually good if we pick it up on time. Thank you very much. Next is Dr. Fairuz for intra-arterial chemotherapy. Please.
How soon could we take them up for combined retinal detachment surgery after the resolution of retinoblastoma? It's better to leave the eye alone.
So if the treatment has come, the tumor is completely regressed.
Not completely, yes, it is showing regression, calcification is there, it is regressive.
No, if it's completely regressed, then you can go for, then what is the cause for retinal detachment you have to see? It's a rhegmatogenous detachment, mostly.
Line detachment.
Rhegmat.
Yeah, during those intravitreal injection, after that the patient starts showing retinal detachment element, and then finally combined with detachment.
But the tumor is completely gone or still there is active tumor?
3 months it's gone, I don't know. We have to follow up.
If the tumor is still active, then we need to continue with the chemotherapy till the tumor is completely regressed.
Do I follow up the patient to call it a complete regression? Because for the past 3 months I do not see activity. It's 3 months after putting the last injection.
For three,
Also, I follow. How long do I follow up to call it a regressed tumor and then intervene?
3 months to 6 months is usually what we take as regressed. Dr. Anirban had a similar situation recently. Dr. Anirban, would you like to share your experience?
If you have an active tumor and you have a rhegmatogenous detachment, I mean, there is no reason why you cannot operate on that patient, but there is a technique of doing it. I mean, for VR surgeons, you would understand better. So you do a non-drainage external buckling for these patients and the detachment resolves. For if you're going to do a vitrectomy in these patients, it's best to wait for the tumor to resolve. And that also is done under melphalan infusion.
Hi, once again to everyone. So I'll take you quickly through intra-arterial chemotherapy and real-life challenges, no financial interests, and my affiliation. So intra-arterial chemotherapy, for postgraduate students, it's important. You might have to go back and read in detail. It's a direct intraocular delivery of chemotherapeutic agents via the ophthalmic artery. Now, how is it advantageous? The good things about intra-arterial chemotherapy and the positive side I'm going to speak is the advantages are increased drug concentration locally into the tumor. It's kind of sending the chemotherapeutic drugs directly to the tumor, minimal systemic absorption and systemic toxicity, and thereby avoids long-term systemic complications. So the drugs that we use are different from what we use in systemic intravenous chemotherapy. We use the VEC protocol, vincristine, etoposide, carboplatin, and these are different drugs. And why am I emphasizing this here? As a secondary intra-arterial chemotherapy where you have a chemoresistance to those drugs, you can always attempt an intra-arterial chemotherapy to salvage the eyes, all right? So thanks to Dr. Kaniko, who actually introduced this technique early 2000s and which was popularized by Dr. Abramson in United States of America as a targeted therapy for retinoblastoma. So intra-arterial chemotherapy focuses only on eye salvage and vision salvage. So that is the first challenge, all right? In country like India and less developed countries where we see advanced disease, where there is a high risk, clinical risk of systemic micrometastasis, probably intra-arterial chemotherapy is not a good choice, all right? Systemic intravenous chemotherapy helps in dealing with systemic micrometastasis, whereas this is very focal into the eye, all right? And to a certain extent, vision salvage. So that is a first challenge. Now, chemotherapy, we know systemic chemotherapy. When we talk about intra-arterial chemotherapy, when comparing to systemic chemotherapy, there can be ocular toxicity, all right? So these are the chemotherapeutic drugs which are going into these small vessels into the babies, which can cause ocular toxicity. It is expensive and, well, we need to have a cath lab and an experienced person, which of course the treatment technique has a long learning curve. We as ocular oncologists, we don't do this technique. We take help of an interventional neuroradiologist or a neurosurgeon to do this technique. And this is my interventional neuroradiologist.
Antithrombolytic.
So what we do is like, assess the situation, plan the drugs, whether it is single drug, double drug or triple drug therapy, and then the dosages. So the entire technique is done by a neurosurgeon. So this was a review article that we recently published in Indian Journal of Ophthalmology. In fact, this was my last page where, we spoke about the strength, the weakness, a SWOT analysis of intra-arterial chemotherapy. So, well, the weaknesses are, as I told you, it can have irreversible vision-threatening complications. It is expensive, and definitely we do have a lack of prospective randomized controlled trials regarding the real results of this. Now, there are threats. Again, as I told you, failure to identify the clinical high-risk features and then jumping into an intra-arterial chemotherapy is more deleterious for the patient rather than doing good. Now, with this intra-arterial chemotherapy, not much in India, with my experience in China, the parents knowing that there is something which can have better effect in controlling the tumor, they always want to go and, there is kind of a forcing of intra-arterial chemotherapy to the child trying to salvage the eye, where the parents doesn't understand that there is a very clear-cut indications for doing an intra-arterial chemotherapy. All right, and sometimes it also happens that interventional radiologist who's not into ocular oncology or who understands the principles of oncology, since there is a newer technique, they kind of go ahead and do these techniques. So these are the downfall of it. So this was a patient actually, one of the patient that I have treated who has already received intra-arterial chemotherapy, and this is how the child came to me. Well, whether they should go ahead with intra-arterial chemotherapy or not. MRI was not done in this child and intra-arterial chemotherapy was started. You can see there is a subtle proptosis already, and this is a group E where a proptosis has happened, and in fact she had an optic nerve extension. All right, and this is how histopathological globe looked like, and the patient received intra-arterial chemotherapy for eye salvage, which is very, very, very dangerous. So there are clear-cut indications. In my practice, I use it for unilateral intraocular retinoblastoma, group B to group D, bilateral RB if it is D and E, where there is a huge desperation to try to save one eye irrespective of the visual potential as a secondary therapy. Contraindications are advanced intraocular retinoblastoma, bilateral IAC if you want a vision salvage, because intra-arterial chemotherapy has a downside. It can lead on to vascular occlusion and the child can have massive choroidal atrophy, central retinal artery occlusion, and not have a vision in that eye. So if you want to save vision in one of the eye, never go for a bilateral IAC, and radiological evidence of optic nerve involvement. Now, group E retinoblastoma is a gray zone where some of the patients where parents really want to try for evaluation. If there is not much of radiological evidence of, sometimes we resort for group E retinoblastoma also. So these are beautiful results of intra-arterial chemotherapy, and especially in group D eyes, it's extremely good. Here you see it. There is vitreous seeds persisting with intravitreal chemotherapy. The entire thing has regressed. A lesion which is very far in the periphery, 2 sessions of intra-arterial chemotherapy, it has regressed. And well, as you can see, peripheral tumor, the same eye, where even the macula, the vision salvage is also done. Not always. It is also associated with bad vision-threatening complications also, choroidal atrophy, vascular thrombosis, as I've mentioned, hyperemia, ptosis. These are common and it resolves. Well, alopecia, does it happen only with systemic chemotherapy? I do have few patients in my series where even alopecia has happened unilaterally in the area of intra-arterial chemotherapy. Now, this is boom. Well, this intra-arterial chemotherapy where has been given to this eyes has complete choroidal atrophy over here. So sometimes it can happen, and because the drugs can cause endothelitis and closure of the vessels. Well, severe choroidal atrophy. In fact, this is a very potential, visually potential eye. And you cannot always predict, although you want to do good for the patient, so you have to be very choosy. And this is how the OCT looks like in this patient. Choroidal hemorrhage, central retinal artery occlusion. So, sorry for this because there is a change from Mac to Windows over here. So group D tumors, yes, it is very helpful, where you can see this is actually 94 and 85, and this is systemic chemotherapy with 47% of vision salvage. So group D, definitely there is a jump in the outcome, like salvage of the eye. So group E eyes, we did evaluate this in our review, and we found there is hardly any benefit of giving intra-arterial chemotherapy in group E eyes. So well, possibly not attempted. Now, the most important thing in our practice in India is, unfortunately, retinoblastoma is seen in the low socioeconomic group. I'm sure everyone agrees to it. And, well, I hardly give intra-arterial chemotherapy. Most of the patients are very poor and they cannot afford it. A systemic intravenous chemotherapy for 6 cycles would cost a patient 60 to 80,000, completing the entire treatment. But in an intra-arterial chemotherapy, the first session, one session would cost around 1.2 lakhs to 1.5 lakhs, and they need a minimum of 3 to 4 sessions. So most of these patients may not be able to afford. There are foundations which takes care of these patients where they're not able to afford such a high cost for the treatment, where Dr. Vikas has shown that systemic chemotherapy definitely gives a very excellent outcome as well. So once we have the public hospitals taking over and having the facility in a public hospital with intra-arterial chemotherapy and the catheter charges, so the catheter we need very small catheters in babies, and catheter actually is costly. It is around 75,000 to 80,000, that itself, with the charges, admission charges, GA charges, everything goes up. So well, if all these things comes down in the future, probably we will be able to give more intra-arterial chemotherapy to these patients. Yeah. So these are the challenges with IAC. Although IAC is one of my favorite treatment modality in retinoblastoma, and most of my patients in China receives IAC, but I would say 98% of my Indian patients receive systemic chemotherapy, mainly because of the financial constraints. We have experts in India. The doctors have a very, they are experts in the technique, but well, finance is definitely a major issue. Thank you so much.
Thank you, Dr. Fairuz. Those were excellent results. Next, I would like to invite Dr. Santosh Honavar, who needs no introduction, for his talk on orbital retinoblastoma. I think he is amongst one of the few people in the world who's got the maximum experience in retinoblastoma, and so he has developed the multimodal therapy for orbital retinoblastoma that has actually changed the treatment protocol throughout the world for managing these advanced cases.
Switch. Okay. Good afternoon. I'll be talking about orbital retinoblastoma, just to mop up the retinoblastoma instruction course. You don't see it very commonly, but when you see it, it's kind of a terrifying situation because it has a very difficult way of managing it, and children go through a very bad phase during the management. So definition is that when a tumor is found outside the confines of the eye, which could mean that it could be frank orbital, it could also mean that it could be optic nerve extension and full thickness scleral extension. Even that is considered orbital retinoblastoma. Of course, it's the minimal variant. Incidence is hugely variable. In India, we have 6 to 30% depending on which part of the country you are looking at. In Mexico, Taiwan, Nepal, Africa, you see the incidence. Africa probably is the highest, 30 to 60% of children there present primarily with the orbital retinoblastoma. These are some of the known facts about orbital RB. It manifests in older children. You don't see infants with orbital RB because it takes time to grow. Mean age is about 3 years. Most of them are unilateral. Unilateral retinoblastoma is often missed. Bilateral, because of poor visual responses, parents may take the child to a pediatrician or an ophthalmologist, whereas unilateral, because the other eye being normal, children may keep seeing well until the retinoblastoma is advanced, and that breaks out into orbital RB. Or obvious proptosis like this without inflammation. So if you see proptosis with flat lids without lid edema, most likely it is orbital RB. But if you see proptosis with lid edema, it could be sterile orbital cellulitis causing proptosis, and that you must differentiate. In a secondary situation, when you have already done enucleation, if a prosthesis were to be fitting properly earlier and suddenly now it becomes displaced, or the implant gets displaced suddenly, that's an indication that there is some growth in the orbit, and that generally is secondary retinoblastoma. You must differentiate whenever you get a child with proptosis, sterile orbital inflammation. It will have conjunctival congestion and lid edema accompanying leukocoria, as you see there. And when you do scan, you don't see a mass, but diffuse inflammation periocular, and that may even extend to the orbit. Sometimes it may hide a subtle orbital extension. So after giving steroids to these children, you have to repeat the scan to see if there is any scleral nodule, which may be hidden by the initial inflammation. So you have to repeat scans twice in such patients. There are many classifications of orbital RB. This is children cancer group classification, which is no longer used. What is used is international staging system for retinoblastoma, where orbital RB is stage 3. Regional extension with overt orbital disease is stage 3A. That's where it fits in. And in AJCC 8 classification, it is CT4. Now, there are 5 variants of orbital RB. Morphological classification: primary, when a child who has not undergone any treatment earlier presents with orbital retinoblastoma. Secondary, this is how it may present: primary orbital RB, or sometimes you may not see it clinically. There may not be any proptosis, or there may be very mild proptosis, but when you do scan, you may able to see an orbital extension. So either it is diagnosed clinically like this, or on radiology or MRI. Now, secondary is when you have already done an enucleation and the child presents with an orbital mass. So enucleation, to prevent it, enucleation has to be performed without accidental perforation. Sometimes when you do enucleation, if you are slightly rough with it, there might be a scleral perforation which will spill the tumor into the orbit. And you should always go for the longest possible optic nerve stump. Anything which is about 15 to 20 millimeter is ideal. Example is this patient where you see optic nerve is thickened here. That means it's involved. If you were to go by the textbook description of 10 millimeter stump, you would still be left with tumor at the transection edge, and that will grow into a secondary orbital retinoblastoma. So you should always go for the longest possible optic nerve stump. Anything less than 15 millimeter, I would consider suboptimal. Let's skip the video. Now, accidental is when somebody does an intraocular surgery for an unknown retinoblastoma. This child actually presented with hyphema with a history of trauma earlier, and somebody did a hyphema drainage and did a trabeculectomy, and few months later child presented with a subconjunctival mass, and in addition there is, you can see, regional lymph node extension. So this is accidental when somebody does cataract surgery with conjunctival flap, or a trabeculectomy, or a retinal reattachment surgery, or vitrectomy for a child with retinoblastoma without realizing the child has retinoblastoma. Overt is when you clinically, radiologically are unable to detect it. A small scleral nodule may get missed on an MRI. Clinically, of course, there will not be any proptosis, but on enucleation, you find that there is actually extraocular extension or optic nerve involvement. This patient has both scleral nodule as well as the optic nerve involvement, because optic nerve is standing stiff like that. Optic nerve has to be very flexible and fall flaccid when you enucleate. If it's standing stiff like this, that means that there is optic nerve involvement. Microscopic is when everything else is undetectable, like radiologically, clinically, you're not able to detect orbital RB, but on microscopy, histopathology, pathologist is able to tell you that optic nerve transection is involved, and you can see here, this is choroidal involvement, this is sclera, and this is extrascleral extension, a flat placoid extrascleral extension. That's again orbital RB, that's microscopic. So microscopic is when the transection is involved or there is extrascleral extension. Now, conventionally, orbital RB was managed with orbital excentration, chemotherapy, and radiation. Either 1 or 2 or 3 modalities in a very haphazard kind of a combination. It had poor prognosis with 70 to 100% mortality. Now, why do we need to combine all 3 modalities in a very logical sequence? That is because each one works differently, and all put together will benefit the child. Chemotherapy reduces the tumor burden. It also takes care of microscopic metastasis. Radiation makes sure that the tumor does not come back in the orbit. Surgery is essential to enucleate. You don't exenterate generally. So you always start with neoadjuvant chemotherapy, which is high dose or adjusted standard dose towards high dose. So when you do that, the tumor shrinks very rapidly. Orbital retinoblastoma shrinks very rapidly with chemotherapy. And once on radiology you find that the orbital component has completely resolved, then you would do surgery. Surgery could be enucleation, extended enucleation, and extremely rarely do you have to do orbital exenteration. Once that is done, the entire area where the tumor was earlier is treated with a well-planned stereotactic radiation. It's important to not to undertreat and include the entire area where the tumor was located pre-chemo. So you base your radiation portal based on the pre-treatment extent of the tumor and continue high-dose chemotherapy for 12 cycles. So if you, for example, if you start with chemo and then do surgery at say 5 cycles of chemo, you have to continue 7 more cycles of chemo. So total is 12 cycles. That is how it goes. Now, doses are given here. I won't expand on that, but carboplatin, etoposide, and vincristine are the standard workhorse drugs. For secondary orbital retinoblastoma, generally we don't have to do surgery because it resolves very beautifully with chemotherapy and radiation alone. But if there is any residual tumor, you perform surgery, which has to be orbital exenteration. Accidental orbital retinoblastoma, if it's just a minor spillover, say somebody has just done a SICS with a small conjunctival peritomy, then you can do en bloc excision of the eye, including the area where conjunctival flap had been earlier made. So that's a very minor variant of orbital RB accidental. But if somebody has done a 3-port pars plana vitrectomy with a large gauge instruments and spilled over in the entire orbit, then you begin with neoadjuvant chemotherapy, then do enucleation, and the whole works like that. Now, overt orbital retinoblastoma, standard is to give external beam radiation and adjuvant radiation. Microscopic, generally, if it is microscopic RB, it is treated with EBRT followed by adjuvant chemotherapy. Now, these are some of the examples of patient where despite chemotherapy for neoadjuvant mode, there is viable tumor. That is the reason why you have to continue treating these children. Some of the case examples. This child was brought with orbital RB, that is the orbital extent, and he had this kind of an appearance. You can even see an anterior scleral nodule, that is the scleral nodule. Following neoadjuvant chemotherapy, you can see eye has gone into a very comfortable phthisis, and at that point you would do a enucleation with a long optic nerve stem. There is no role for doing orbital exenteration. Then there was radiation and then adjuvant chemo. This child, you can see, was very uncomfortable. After one cycle of chemotherapy, the tumor has reduced to the extent that we were able to pull the lids over and do a tarsorrhaphy. So child becomes very comfortable and eye has gone into phthisis. Then you would enucleate. This child also, you can see, eye has shrunken into a very gross phthisis. That's exactly the time when you enucleate. So radiologically also you have to confirm that the extraocular component has resolved. These were earlier considered untreatable, like patients who had cavernous sinus involvement. They were considered untreatable. They were only given palliative treatment. Now they are treatable because you can see that after neoadjuvant chemotherapy, all that is left is at the superior orbital fissure, which can easily be radiated. Of course, the child did need enucleation. Now, how beautifully optic nerve component resolves is seen in this picture. You can see thick optic nerve pre-treatment. Following neoadjuvant chemotherapy, optic nerve caliber has become normal. Then you would do a enucleation with a long optic nerve stump and go ahead with the rest of the treatment. Cosmesis is assured if you are if you're not planning to do orbital exenteration. This is a child following completion of treatment. She can wear a nice prosthesis. One more child, you can see her eye went into a beautiful phthisis, and then we could do enucleation despite radiation, which is well planned. She has a reasonable amount of cosmesis with a custom ocular prosthesis. This is a secondary orbital retinoblastoma treated, and the child is now able to wear up. Earlier, these were all exenterated with very limited cosmesis. This is the only patient that I have done in the last several years where orbital exenteration was required, because despite 12 cycles of chemo, child still had residual orbital RB. Treatment complications are mainly related to chemotherapy and radiation. There is more than 95% survival in orbital RB if you actually treat them with multimodal treatment. So I would conclude saying that orbital RB is difficult to treat, but if you plan your treatment carefully, starting with neoadjuvant treatment, do surgery which is minimalistic surgery, not exenteration, at an appropriate time, and then follow it up with radiation and adjuvant chemotherapy, these children do have a chance of survival as good as any other child with retinoblastoma. Thank you so much.
Thank you, sir. The newer treatment modalities have really altered the way these cases were managed, and the survival has drastically improved. So, have you seen some difference between patients who got just optic nerve involvement whereas orbital involvement? Is one group faring better than the other?
They're not really faring better. Ultimately, they all settle down in the same way. Optic nerve extension actually has a very, I would say, slow response to chemotherapy, whereas orbital RB melts with chemotherapy. So in optic nerve extension, although the response to chemotherapy is slow, you're not treating that by doing chemotherapy. You're also treating micrometastasis. So that way you're successful. Anyway, you have to do, enucleation and then radiation as well.
Thank you very much. Any questions? We can just take one or two. So thank you very much. Thank you everybody. So we move on to the next IC, Dr. Fairuz.